plasmacytoma is a type of tumor made up of abnormal plasma cells that can develop in soft tissue or bones. Can a plasmacytoma have a different genetic makeup than the rest of your myeloma? In this video, we'll explore whether myeloma specialists recommend biopsying and genetically testing these tumors to uncover potential differences. Should plasmacytomas be biopsied and tested genetically?
This is a clinical question. I guess I would make the argument that wherever the plasma cell is proliferating, and if it's proliferating at different locations, so you've got a bone marrow where there's plasma cells, but now if you have a solid tumor like a plasmacytoma, I would still argue that you want to test that particular site because there's no assurance that the plasmacytoma has all of the same genetic mutations and variations as the tumor that's in the bone marrow.
The word plasmacytoma has many connotations. So the more imaging we do, the more we realize that myeloma is a lumpy, bumpy disease. A lot of patients have solid foci of disease in the bone marrow. We call them focal lesions. A plasmacytoma tends to imply a lesion at a specific site that's grown to form a tumor. And often there's a differential diagnosis problem. So is it myeloma? Is it a plasmacytoma? Is it a sarcoma? Or is it another type of metastasis to bone? So you need to have the biopsy to see the plasma cells, characterize them, to know what you're dealing with, because it turns out plasmacytomas are quite sensitive to radiation. And so you could be internally fixed, irradiated, stabilized, and then you can get on and treat the rest of the disease throughout your body. Some people have isolated plasmacytomas, and if they're small and you do an MRD test somewhere else in the body and there's no cells there, maybe you could just get away with treating it locally.
The question that comes up is whether one should biopsy a plasmacytoma in a person who has a history of multiple myeloma. And there's two aspects to this. There's the academic aspect. We know that there could be genetic differences in that plasmacytoma that may not be present in the remainder of the cells in the bone marrow. But one challenge to that is that even if you do that, what if you biopsy in a site that doesn't have that change? Were you to biopsy 10 times, or were you better off maybe getting more and more samples, or even sampling more plasmacytomas? So I think practically it's not that important unless something happens that the patient is not responding to the treatment. So in my practice, I don't do repeat biopsies of plasmacytomas often unless something is happening that makes us worry that we're not seeing the expected behavior. And that could be either growth of the plasmacytoma because somehow it's been refractory to the drugs being used. And that is possible because sometimes plasmacytomas may be areas with slightly more advanced myeloma cells, more clonally advanced. We can sometimes see, and I've seen a few times in my practice too, that the plasmacytomas, they can start depositing proteins, amyloid-like proteins, and they may grow. They may even have symptoms and pain because of this. So that may be another reason why something may not go in the direction we think it should be going. We can sometimes use plasmacytomas also to gauge response to treatment. So we have a person who has multiple plasmacytomas and we start therapy. It's something visual that we can see that the medications are working.
If you found this video helpful, consider giving us a like and subscribing to HealthTree University. Our mission is to educate patients and their care partners and spread awareness about multiple myeloma. We'd like to thank our doctors, our sponsors, and of course our audience for making this video possible. See you next time on HealthTree University.